So that leaves me just to give everyone a warm welcome. So it's good to see you here. And we're delighted today that Dr. Junaid Arshad is going to be talking to us about potential biomarkers in the treatment of neuroendocrine neoplasms. So, Dr. Arshad is a GI medical oncologist and assistant professor of medicine at the University of Arizona Cancer Center in Arizona, US. He both does clinical and basic research with a focus on neuroendocrine tumors, and he serves as the institutional principal investigator on several industry-sponsored and cooperative group NET trials. So he's got an interest in both sort of physician scientist roles, predominantly centered around trial work with nets, but I'm sure we'll be talking to us about lots of other aspects. And also to note that he is keen on multidisciplinary collaboration and mentorship of the next generation of us net specialists. So without any further ado, please take away.
Thank you very much, Kate, for a kind introduction. And good evening to everyone in UK and good morning to everyone in US. I want to sincerely thank the organizers for the opportunity for me to speak today and a part of this important discussion. And it is my absolute pleasure to share this space with the colleagues who share the same passion for advancing the care for patients with neuroendocrine neoplasms. And today we'll be talking about like potential biomarkers and the treatment of neuroendocrine neoplasms. Biomarkers in neuroendocrine neoplasms is a rapidly evolving field and just tells us how we diagnose, classify, and treat these complex tumors. So we will just dive right in. We have up 50 slides. Hopefully, my goal will be to finish all the slides within time. Okay, so we'll be covering like the introduction, talk about some classical biomarkers we already have and are in already use. The main focus of the talk will be on molecular and genomic biomarkers and how they are shaping our future for management of neuroendocrine neoplasms. Introductory slides, we know neuroendocrine tumors are a heterogeneous group of neoplasms. They arise from neuroendocrine cells, which are present throughout the body. So these tumors can literally happen anywhere in the body, but most commonly they're found in the GI, gastrointestinal system, or bronchopulmonary systems. Over the last decade, these tumors have seen a substantial rise in incidence, which is attributed to advanced imaging such as endoscopic ultrasound or high resolution imaging, cross-sectional imaging such as CT scan or MRI. And the incidence for small bowel neuroendocrine neoplasms is 1.2 cases, whereas for pancreatic neuroendocrine neoplasms is 0.7 cases per 100,000. And it's not really just the incidence that's on the rise. Same goes for prevalence. And as per some reports, the prevalence of neuroendocrine neoplasms is higher than the combined prevalence of hepatopancreatic or biliary cancers. So it is right to say that the neuroendocrine tumors may be uncommon, but not rare. These are heterogeneous tumors which are characterized by indolent growth, and they secrete biologically active amines and vasoactive peptides. And when they do secrete these hormones, they're called functional tumors, otherwise non-functional tumors. Neuroendocrine neoplasms are also classified based on degree of differentiation into well-differentiated and poorly differentiated. And based on the WHO criteria, we take into account the grade and the Ki-67 index. There is also a category of mixed neuroendocrine neoplasms, which has an endocrine and a non-neuroendocrine component. There has been a lot of advancements in the therapeutic and diagnostic setting, especially over the last couple of decades. And what we really lack are the biomarkers, which can help us to understand the question of treatment sequencing and some of the other issues associated with lack of biomarkers, so which is an area of critically high unmet need. So I will start off with a case. A 62-year-old woman with a history of stage 4 grade 2 well-differentiated neuroendocrine tumor with liver metastasis. She was diagnosed 2 years ago, and she was somatostatin receptor positive. She was started on octreotide, long-acting, and was initially stable, but now presents with an increasing abdominal pain, weight loss, and diarrhea. And the most recent imaging shows now that her liver metastases have progressed, and there are several new peritoneal lesions. And then there are all these treatments in the treatment algorithm. How do we decide next best treatment course? So we'll go into the talk and we'll answer our question in the end. So, which brings us to our starting point of biomarkers. What are biomarkers? So biomarkers are often molecules. They are found in blood, other body fluids, or tissues. They can signal the presence, subtype, prognosis, and response to treatment. Now, biomarkers can be prognostic, where they indicate the outcome without treatment, such as Ki-67 index, or they can be predictive, where they indicate the benefit with the treatment. For example, somatostatin receptor 2 and DLL3. There are some classical biomarkers like chromogranin and synaptophysin, which are in use in the diagnosis of neuroendocrine neoplasms for last several decades. And there are some others like gastrin and glucagon, which are functional biomarkers to detect the tumors which secrete these hormones. But our focus really today is on genomic and proteomic markers, like how they are currently in development, what options are available, and what is their current clinical use. And when you decide treatment based on certain biomarkers and molecules, it brings us to the concept of precision medicine. So precision medicine is basically based on genetic information that can help us choose the best treatment option for a subset of patients or for any single patient. And it's not just really the for use for diagnosis purposes. It can be used to establish recurrence for prognostication after initial resection, or it can help us decide what interventions or what treatments not to use. It can help us guide which subgroup of patients is at risk of particular toxicity, especially like in terms of mortality and morbidity. So one classic example, one perfect example of precision medicine in neuroendocrine neoplasms is like somatostatin receptor type 2. We have a target and we have therapy such as somatostatin analogs or peptide receptor radionuclide treatment with lutetium dotatate. So we'll start with well-differentiated neuroendocrine tumors. We know that mutations in neuroendocrine neoplasms, they affect the key cellular mechanisms such as cell cycle regulation, DNA repair, epigenetic control, and this is consistent along several primaries like small bowel, pancreatic, and pulmonary. And these alterations, they drive tumorigenesis by disrupting differentiation and promoting proliferation, invading apoptosis, causing dedifferentiation. And just a schema, just to show that neuroendocrine tumors are a highly vascular group of tumors, and they have a 10-fold higher intratumoral density as compared to their other cancer counterparts. And this increased vascularity is related to several growth factors like vascular endothelial growth factor, fibroblast growth factor, colony stimulating factor, various semophorins, their cognate receptors. And it is because of this increased vascularity in these growth factors, several tyrosine kinase inhibitors with anti-angiogenic properties, they are currently used in the treatment of well-differentiated neuroendocrine tumors. And in addition to these, like growth factors, we also have somatostatin receptors like type 1 to 5, commonly type 2 which is targeted by somatostatin analogs and PRRT, and they lead to activation of downstream phosphotyrosine phosphatase pathways and are involved in cell cycle regulation. So let's talk about like what genomic biomarker candidates are available in well-differentiated small bowel neuroendocrine tumors. So the well-differentiated small intestine neuroendocrine tumors are genomically stable with very few recurrent mutations, most notably in cyclic-dependent kinases, commonly referred to as CDKN1B and CDKN2, and almost seen in 8 to 10% of cases. And instead, the tumorigenesis is usually driven by chromosomal alterations like chromosomal deletions and epigenetic dysregulations. And rather than having a classical driver mutation, which we see in some of the other cancers. And as for some studies that there may be driver mutations present in as much as 50% of patients, and almost 20% of these can be targeted. This is usually seen in high grade tumors. And when these molecular mutations are present, it can impact or predict the outcome. Mismatch repair deficiency, although very common in a lot of other GI tumors, is rarely seen in small bowel neuroendocrine tumors, and the tumor mutation burden remains low. In contrast, the well-differentiated pancreatic neuroendocrine tumors, they frequently harbor mutations in ATRX and DAX genes, which are very different from the pancreatic adenocarcinoma counterparts. And then this loss of ATRX and DAX genes is correlated with shorter disease-free survival and overall survival, which indicates that, despite the well-differentiated histology, it is a very aggressive clinical course. Now, the problem lies that the DAX and ATRX has not been further validated, and there are varying reports of different prognostic value depending on the stage of the tumor. We'll talk about ALT as well, which is alternative lengthening of telomeres. It is associated with mutations in ATRX and DAX, commonly involved in telomere maintenance and usually tested with FISH testing. And it is a telomerase independent mechanism, which is linked to ATRX and DAX, present in almost 10 to 20% of pancreatic neuroendocrine tumors, especially with the size less than 2 centimeter. And ALT positivity is associated with high recurrence risk and increased metastatic potential and worse disease-free survival. So this can definitely help us decide for tumors that are smaller than 2 centimeter that, to establish the recurrence potential. So small doesn't necessarily mean benign behavior, and we can potentially use ALT for a risk-adapted surveillance and post-operative management. Sporadic pancreatic neuroendocrine tumors contain larger than expected germline mutations, and these mutations or / alterations affect their through 4 main pathways, the central of which is MEN1 tumor suppressor pathway that is involved in chromatin modification and remodeling, and involved in telomere maintenance through ATRX and DAX genes, and interact with mTOR pathway, which is then further involved in TSC1 and TSC2 alterations, also involved in DNA damage repair, which can be targeted in with PARP inhibitors. Now I want to talk about the temozolomide as well. Temozolomide is an alkylating agent, causes DNA mismatch repair and causes tumor cell death. It has been around the block for last several decades for glioblastoma multiforme, and the MGMT status is predictive of response and prognosis. for glioblastoma multiforme patients, but the reports of efficacy of temozolomide in pancreatic neuroendocrine tumors is mixed, and that variability is related to MGMT testing. So MGMT is a DNA repair enzyme, um, also known as methylguanine methyltransferase, and it serves as a predictive and prognostic biomarker in glioblastoma multiforme, but currently still under validation in pancreatic neuroendocrine tumors. Several retrospective studies have shown the benefit of temozolomide in pancreatic well-differentiated neuroendocrine tumors, and then there is this prospective study, ECOG 2211, which is a phase 2 randomized multicenter study that compared the combination of capecitabine and temozolomide in patients with grade 1 to grade 2 well-differentiated neuroendocrine tumors, showing a statistically significant and a clinically meaningful progression-free survival, median progression-free survival, I should say, of 23.2 months as compared to 15 months. And we can see that, and the median overall survival remained, was not statistically significant. And the exploratory analysis from these from this study showed that the low MGMT score and promoter hypermethylation of MGMT is associated with increased response to telozolomide. So as we discussed, like low MGMT expression or methylation, it can be a predictive biomarker of increased sensitivity to temozolomide in pancreatic and some other well-differentiated neuroendocrine histologies. NETtest is also one of the rising biomarkers. It is a multi-gene, multi-analyte assay consisting of 51 genes that measures circulating transcripts associated with neuroendocrine tumor activity. High sensitivity and specificity greater than 90% has been reported in some studies for detecting disease. It can be used for diagnosis, treatment response monitoring, and detecting early recurrence. It offers like a real-time assessment of measuring or gauging the recurrence before the radiologic recurrence. And NETtest 30 days post-resection reports the highest accuracy. Currently, this test is still under validation in a lot of prospective clinical trials, especially SWOG 2104, which is testing the use of capecitabine and temozolomide in the adjuvant setting for high-risk pancreatic neuroendocrine tumors. Just to summarize that, the next generation sequencing in neuroendocrine tumors is not ready for routine clinical use. The reason for that is that the actionable alterations are uncommon, but the field is moving in that direction. We will have more targetable drugs, more targetable mutations with drugs. ALT, is it really ready for use in pancreatic neuroendocrine tumors? Can we use this in smaller tumors less than 2 centimeter to determine the post surgery risk assessment for recurrence? MGMT, the issues lies with testing with immunohistochemistry versus methylation assays, and NETtest in the post-op setting use. All these tests are currently in testing. All these biomarkers are currently in further testing, waiting validation to be routinely used in the clinical use. We will switch gears and talk about the genomics and biomarkers that are associated with neuroendocrine carcinoma, the poorly differentiated neuroendocrine carcinoma. The main altered genes in this setting are for the lung neuroendocrine carcinoma are TP53 and RB1, and the other extrapulmonary neuroendocrine carcinomas, they often show altered genes and pathways that parallel their non-neuroendocrine counterparts. Um, so primarily in small cell lung carcinoma, we see TP53 and RB1 alterations, whereas the grade 3 pancreatic neuroendocrine carcinomas over here show ATRX and DAX mutations. An important thing to notice over here that this abstract is featured from 2016, and in that time, grade 3 well-differentiated neuroendocrine tumors were not a separate entity and were included in the WHO 2019 classification criteria. So it is prudent that we notice this difference over here. I do want to highlight that the highlight of this grade 3 neuroendocrine tumors are different from the poorly differentiated neuroendocrine carcinomas, and majority of those patients do harbor TP53 mutations. And as discussed before, that these grade 3 well-differentiated neuroendocrine tumors and carcinomas, they differ significantly in their molecular profiles, despite the fact that they have overlapping proliferation indices. And grade 3 neuroendocrine tumors, they retain those mutations with ATRX and DAX, and whereas neuroendocrine carcinomas commonly show TP53 and RB1 mutations. And we can see that the difference between the large cell and small cell histologies too, in terms of their differing yet resembling molecular landscape. So a lot of information in the last two slides. I'd like to just summarize over here that grade 3 neuroendocrine tumors are different from neuroendocrine carcinomas. Neuroendocrine carcinomas, primarily TP53 and RB1, and neuroendocrine tumors well differentiated DAX, ATRX, and MEN1. And neuroendocrine carcinomas of extrapulmonary origin, they have different alterations, like those colorectal harboring APC and BRAF mutations. Tumor mutation burden, even in the neuroendocrine carcinomas, remains low. Some may have greater than 10% tumor mutation burden, but the first line response to chemotherapy just remains still under investigation and is thought to be lower than their non-neuroendocrine carcinoma counterparts. Immunotherapy remains minimally efficacious in well-differentiated neuroendocrine tumors of any grade. Single agent after progression of initial chemotherapy has not proven to be beneficial either. Several retrospective studies have pointed out that there is no benefit of combination chemoimmunotherapy in the frontline setting. However, prospective randomized SWOG 2012 studies currently investigating the use of carboplatin etoposide with atezolizumab in extrapulmonary neuroendocrine carcinoma. There have been several trials like DART, DUNE, and NEPINEC that have shown the efficacy of combination immunotherapy in the second line setting, and they all have comparable median overall survival benefit. I do want to talk about delta-like ligand 3, commonly referred to as DLL3. It's an inhibitory ligand of the Notch pathway. It has emerged as a potential biomarker for diagnostic and therapeutic strategies in neuroendocrine neoplasms. It has been shown to have overexpression, and in neuroendocrine carcinomas, it is associated with tumor progression, prognosis, and dedifferentiation. It is expressed both in pulmonary and extrapulmonary neuroendocrine carcinomas, and overexpression is associated with lower progression-free survival and overall survival, highlighting both the prognostic and predictive role of this novel rising biomarker. And its restricted expression in normal tissue ooze and enrichment in the neuroendocrine carcinoma make it a promising target for bispecific T-cell engagers, one of which is called tarlatamab. And tarlatamab is currently FDA approved in extensive stage small cell lung cancer, regardless of the DLL3 status, as we're further validating and the role of DLL3 in terms of targeting with bispecific T cell engagers. And it's not just only in small cell lung carcinoma. We have also seen substantial responses in extrapulmonary neuroendocrine carcinomas. A similar agent to tarlatamab is called obrixtamig. It's also a CD3 T cell engager with different pharmacokinetic profile as compared to tarlatamab, and have shown responses in DLL3 and DLL3 low extrapulmonary neuroendocrine carcinomas. The data that was presented earlier this month in ASCO 2025. And ASCO from last year have shown the efficacy of tarlatamab in an EPC study of prostatic neuroendocrine carcinoma in the advanced refractory setting. So a lot of targeting agents are currently under development, targeting the Notch pathway, especially DLL3. This marker is further being investigated in larger and randomized clinical trials to study the effect of responsiveness as well as the effect on the progression-free survival and overall survival benefit. So how do we test for these genomic alterations? We've discussed tissue testing remains the preferred method and remains the gold standard. Several panels exist. The efficacy or superiority of one panel over the other has not been established. Liquid biopsy can be used as an alternative. As per one study, that there was an additional 20% of patients had additional alterations which were not detected. So gold standard for tissue and ctDNA is always using an alternative, especially in the setting when there is no tissue available. To summarize this section of the talk, extrapulmonary are not the same as small cell lung cancer, and well-differentiated neuroendocrine grade 3 are different from poorly differentiated neuroendocrine carcinomas. Variable mutational profiles, variable genomics despite the biologic similarities. Mutations in certain genes can predict outcomes, not clear if truly predictive of efficacy, still requiring further validation. Immunotherapy remains ineffective, no proven benefit in the frontline setting with chemotherapy, currently under investigation. DL3 is a rising biomarker, as we talked, and we can use tissue biopsy as well as liquid biopsy. Can we use liquid biopsy for all? Still remains to be further proven and validated. I will change gears about here to talk about peptide receptor radionuclide therapy, also referred to as radioligand therapy, especially with lutetium dotatate. Neuroendocrine neoplasms across the different paradigm of primaries, they do express the somatostatin receptors, whether they are from bronchopulmonary or GI systems, and we can use these somatostatin receptors for diagnostic imaging such as gallium dotatate. This gallium dotatate imaging can help us to determine the positivity for somatostatin receptors. However, it can also help us in extensive staging and stratification of patients into low, intermediate, and high tumor burden. One of the shown pictures shows the difference between the three in terms of the tumor burden. So why is there a need for having biomarkers or predictors for peptide receptor radionuclide therapy? Peptide receptor radionuclide therapy with lutetium dotatate is a very effective therapy, but this effect and this efficacy varies across, it varies considerably from grade 1 to grade 3 neuroendocrine tumors. We know the efficacy from NETChatter clinical trial, especially from pancreatic histology, but we also know that 12% of patients have progressive disease even with peptide receptor radionuclide therapy. And it is imperative, and it's an area of critical unmet need to have a biomarker that can help us determine and find out those patients so we can avoid using peptide receptor radionuclide therapy in those patients. And also, the PRRT is associated with certain hematologic toxicities that can lead to significant mortality and morbidity. And if we can use these biomarkers to highlight those patients to avoid these severe toxicities, that further highlights this area of critical unmet need. Do we have any markers? There have been several stratification models. There have been several algorithms that have currently been used that may offer some prognostic significance, but they haven't really shown any benefit in terms of the predictive nature of those biomarkers. So we have no established tissue markers that can reliably predict the role of PRRT. Radiogenomics have also been currently under study for external beam radiation treatment, but their role has been extrapolated to the use of PRRT. But do they really work for systemic radionuclide therapy? The answer to that is still not available. I would like to talk about the molecular profiling, something referred to as the PPQ quotient. Um, the PPQ quotient combines the NET test and the PRRT predictive quotient. So it is a blood-based molecular tool where we combine the NET test transcriptomic profiling and along with a mathematical algorithm to predict the response to PRRT. And as for some studies, we can, predict the therapeutic efficacy with an accuracy of as high as like 90%. So we can personalize treatment. And it has been validated in some cohorts. And we know that when we have a positive PPQ test, it shows improved progression-free survival and tumor shrinkage, and a negative result is associated with minimal response. Uh, associated with minimal response. I mean, this approach may move. Sorry. Sorry, I think I moved the slide too quickly. Okay, so a negative PPQ just shows there is minimal response and need to consider alternative therapies. Now, this approach is still currently under validation, not available for clinical use, have been in study in some ongoing clinical prospective trials, and should not be widely used in the clinical guidelines for decision making. So I wanted to share this slide to see how precision oncology and precision medicine, along with radionuclide therapy, can affect our decision of choosing the patients who are more likely to benefit from the PRRT, and especially risk stratification, those who are at high risk of toxicities, including the hematologic toxicity with therapy-related myelodysplastic syndrome. I'll change gear and talk a little bit about the Tumor Miner project at National Cancer Institute, which is one of my collaboration with Dr. Heidi Del Rivero. As part of a prospective National Cancer Institute study, we're banking samples from all neuroendocrine tumors and testing them to build a database for several ongoing biomarkers. And I'll share some of the results we've had out of this Tumor Miner project. We have shown that the somatostatin receptor positivity with IHC immunohistochemistry correlates really well with RNA sequence expression. We have also shown that somatostatin receptors are present throughout the range of neuroendocrine neoplasms, paragangliomas and small cell lung cancers, like the poorly differentiated ones, also express somatostatin receptor 2, and adrenocortical ones adrenocortical carcinomas have high expression of somatostatin receptor 5, whereas the gastro and pancreatic neuroendocrine tumors express both somatostatin receptor type 2 and type 5. We have also shown as part of this tumor minor project that somatostatin receptor 2 expression is strongly correlates with NeuROD1, and there is high level of expression of somatostatin receptors in small cell lung carcinoma, as per one study, like, cohort of almost 48% of patients having somatostatin receptor type 2 in the small cell histology. Now, this correlation has been proven in cell lines and primary small cell lung cancers and some of the other cancers like GI, NET, pancreatic, that this somatostatin receptor type 2 correlates with NeuROD1, and which just provides us an opportunity that the involvement of NeuROD1 is an RNA transcript, and in the setting of this aggressive histology, it may be a potential target for therapeutic intervention. The somatostatin receptor targeting in small cell lung carcinoma has presented a rationale in the past to use radiopharmaceutical therapies, but it has been dealt with substantial challenges, including toxicities. I'd also like to talk about the delta-like one homolog, also called DLK1. It is a transmembrane protein involved in developmental signaling and is expressed in several other neuroendocrine tumors. Its overexpression has been associated with tumor proliferation, stemness, and poor prognosis. Can be a potential biomarker and therapeutic target in high-grade and aggressive neuroendocrine neoplasms. Also affects the Notch pathway, similar to the LL3, but have several targeted agents, one of which is ADCT701, have shown initial efficacy in the cell lines, and then currently there is a first-in-human phase 1 trial ongoing, showing the efficacy of and the dose escalation design, a 3+3 dose escalation enzyme design studying the effect of ADC 701 targeting DLK1 agent. Currently, this trial is ongoing. I'm not familiar of any final results, but there have been additional initial results that have shown to proven efficacy in these patients. This is our poster from the ASCO earlier this month, the data that also came out of tumor minor project. We highlighted the expression of TROP2 in gastroenteropancreatic neuroendocrine tumors, the biggest analysis so far, showing that the TROP2 overexpression is present in almost 50% of pancreatic neuroendocrine neoplasms. Does correlate, TROP2 overexpression does correlate with lower overall survival. However, we're still in the process of completing the analysis to see how this TROP2 overexpression is related to Ki67 and grade and some of the other clinical variables. So more to come on this, currently further in development. So our future for neuroendocrine neoplasms and our hope for neuroendocrine neoplasms is to have as many biomarkers as available for molecular profiling through tissue testing or liquid biopsy to find novel diagnostic and therapeutic targets, which can be used both for prognostic and predictive purposes. So I will, so coming back to our case, we discussed all the extensively available. So in that patient, in the other next generation sequencing that showed mutation in the mTOR pathway, especially in TSC2 gene, we've chosen everolimus for her treatment, despite that this pathway still, this biomarker still needs to be validated. There were several concerns about use of PRRT in the peritoneal disease. Patient was very eager to start everolimus and has been taking for 8 months and currently still have stable disease. Does have moderate toxicities, but nothing that requires dose modification or dose reduction. So currently she has her last scan that showed stable disease. So for conclusions, I think this is one of my last slides, not really the last slide, but most neuroendocrine tumors do not have actionable alterations. But with better testing, discovery, and development of several targets, that's likely to change. Still, there is some use of ATRX, DAX, and ALT testing to predict recurrence, although the use has not been allowed in the widespread clinical setting, still requiring further validation. Substantial number of MGMT is also one of the developing biomarkers in pancreatic neuroendocrine tumors, especially when we're considering treatment with temozolomide. In the setting, we're looking for a response. Neuroendocrine carcinomas can harbor actionable alterations. Targeting these with existing agents still remains a question. Immunotherapy still remains effective, but only a small fraction, 15 to 20% of neuroendocrine carcinoma patients, no reliable predictors exist. DL3 is also a rising and predictive biomarker requiring further testing. NETChatter and PPQ may have a role in predictive recurrence, still under requiring prospective validation. And we didn't talk much about CHIP. That may be one of the markers that can help us determine the hematologic toxicity after PRRT. So really to just wrap this up, I just put it this way: if you see it, send it, and we'll sequence it to determine what alterations are available. For acknowledgement, Dr. Hadira Del Rivero is a very close friend, a mentor, and a colleague, and a collaborator. Thank you very much. I'll be happy to take any questions.
Thank you so much for that really good overview of the sort of biomarkers and things that are available for us at the moment. So, Selena can't talk,
Uh,
but Sonia, John, do
I'm
either of
just,
you have
can
any
you,
questions?
you just think, can you hear me?
Oh, yes, we can.
I've done it.
Just say something, anything now, because you can.
Thank you. Thank you, Kate, for stepping in like that. Sorry, carry on questions.
But yes, Sonia, John, have either of you got any questions? If not, I'll ask some.
Sure, I have some questions, and I'm sure other attendees might too. And thanks for hosting, and thanks for presenting. Um, I have several questions I'm picking. So I guess this is really interesting. I've been looking at some biomarkers in a biomarker project in NETs for a while. So be happy to talk about that maybe offline. That could be fun. But my first question is one of like what my understanding, is that these like ctDNA and other similar liquid biopsies could be tough to do. Like it's not widely available. So like I'm working on a biomarker project in glioblastoma, and we're trying to focus on what can you do that's kind of everywhere or anywhere that's easy to do. So I guess that's my kind of like first question. It just confirming that these may not be super readily available, that they're a pain, or are they not? Maybe I've just got it all wrong.
No, John, this is absolutely correct. So part of this is that we don't have any established panels.
Yeah.
We don't have any established gene transcripts. So what we're doing over here is like random. We're using some of the existing NGS methods that we have for other tumors. And those are somewhat helpful. Like I was saying that, let's say if you have a neuroendocrine carcinoma patient from colon cancer, they will still show you APC. They will still show you KRAS and NRAS because they are coming out from colon. So, but does it really mean that there are no other actionable alterations in that? We do not know that. So we do have to, it will require specifically studies of those assays catered to neuroendocrine carcinomas. So what we really are needing is one starting point that just tells us that these are the set sort of transcripts that are seen in this, and then we can take it from there. And that starting point has already been now under investigation. That NETtest provides, it's a 51 gene and that assay, and prospectively, this SWOG 2104 study, it will help us understand what transcripts are available. And then we can further build on those gene assays. If 51 genome, and we can add several other genes to it to look for it. So I think it has started already. It's just a matter of time that we further develop some of those assays.
Cool. So, and the net test seems really interesting because it does seem like my understanding is like it's doable, it's deployable. As I guess a kind of a follow-up, what do you think about KI67 and where that might be going, or KI67 in the context of these upcoming changes, hoped for upcoming changes?
So I think what KI67 is, it is one of the very few biomarkers we have, and it's good that we have it. We commonly use it. I say that it is a biomarker, not a perfect biomarker.
Yeah.
There are rooms for several improvement. In the clinic, we have seen several patients who have grade 1, less than 3% KI67, but yet they have a very aggressive clinical course with lymph node metastasis, with liver metastasis. So there is a missing piece in the puzzle. And I think that this missing piece in the puzzle can be solved by having molecular biomarkers or genomic biomarkers. So I am very hopeful that in the next 5 to 10 years, we'll have some biomarkers, molecular biomarkers, that will be added to the classification to it. In addition to KI67, we'll have further stratification, especially grade 2. I always ask that question, does 5% of grade 2 is the same as 19% of grade 2?
Right.
So there's a lot of room for improvement, and I'm very hopeful that there will be a section of inclusion of molecular biomarkers in that grading system.
Right. Well, and NETR2 with its crossing over, right, beginning at 10% instead of 20 is pretty interesting. So
Yes.
Great. Maybe we can connect later too. I'd love to talk with you about this more if you'd be amenable to me.
Absolutely. Please, I have listed my email. I'm always available for collaboration. Please feel free to reach out.
Great. Thanks. It'd be fun. Thanks.
Thank you.
Right. Well, if John's finished, I think as we've only got 5 minutes left, I'm going to ask you a bit of a provocative question that someone asked me recently. And I won't tell you what side of the fence I fell on, but hopefully it'll be pretty obvious to most people here. But it was that someone said that we're doing a lot of profiling and finding out a lot of information about individual patients. And actually, how helpful is that? Because are we sort of in a wood for the trees situation in that with all the vast amounts of data that we've got, is it meaning that actually it's hindering rather than helping us finding the things that we should be targeting?
Thank you for the question, Kate. It's not an easy question to answer, but
That's why I'm asking, because I wanted help in answering the question if I ever get asked it again.
So the challenge lies with the tumors in itself. They're very heterogeneous. There are several classifications of it. And can we just solve all this puzzle by just one sort of gene testing? The answer to that is, likely no. There is going to be several, but I personally believe it's especially harder when you're starting something. And for right now, I think this is the starting point. But what really makes me feel better about this, that at least we have some lead points. We have certain good candidates that may become further validated or studied. This is in addition to the fact that NETs, they have face other challenges like funding shortages and rarity and harder to run clinical trials. and the fact that we lag behind the rest of oncology in this therapeutic development paradigm. So taking into account all these issues, I personally believe that we should continue to sequence, and it is because of this sequencing we have some lead points, and now we have to just take these lead points and see how they develop through this, how they pass through this therapeutic development. Like all the markers I've mentioned, they all are involved in prospective studying. So once we start results of this, once we start seeing the results of these clinical trials, we will know for sure how net test is. Is it useful or not useful, and how in what setting will this be useful? And that will lead to, like, as I say, each clinical trial answers one question but raises 10 more. So then, when you start entering into this, start solving the puzzle-like thing, this is how it usually starts. It may feel a little bit, that we're like shooting a dart in the dark, but I think light is not far away. That's how I personally feel.
That feels like a very good, poignant statement to finish on. And thank you for answering what was a bit of a mean question, really. But I definitely know that that's been cropping up a few times with people, and I totally agree with you. I think we're in a situation that I think a lot of other research fields aren't in for a lot of different reasons, which makes it challenging for lots of reasons. So, yes, well, I mean, once again, thank you very much for what was a brilliant talk. And Selena, I don't know if you've got any last comments before we disappear.
Well, you've done my thanks. I now have sound. So apologies for my gremlins in my system today. I have no idea what's going on. But thank you very much for coming. Thank you, Dr. Arshad. That was a fantastic talk. I can't normally, they're normally a little bit too scientific for me, and I struggle to follow, but I really followed your talk today and found it really interesting. So thank you for that, which will be great when we put our video up, because obviously then the thing, when it's a little bit more patient orientated like this, with things that people can relate to on a less scientific level, that I found, it's great it's great because more people can interact and more people can understand and maybe get the answers that they are looking for. So, and they don't really know where to turn. So thank you very much. And
can I ask one
yes,
question
Sonia,
before we close? It's probably off topic in a sense, but I've got a question where I have a tracheal deviation to the right, and I have a lung bronchial carcinoid. Is there a correlation between these two?
So correlation between the tracheal deviation and carcinoid?
Yes.
It's
one of the doctors has said, sorry, go ahead.
Sorry. No, I'm sorry. I'll let you finish before I answer.
So one of the doctors said, oh, it'll be to do with your carcinoid, it's pulling it. And I'm going, well, how does that happen? Because I've always got the whys, the hows, the whos. So that's my question. How has that occurred?
So, sorry, there was like a little bit drop in the signal. So you want to know if there's a correlation between the tracheal deviation and the carcinoid tumor? Did I understand the question
yes,
correctly?
That's correct.
I can't give a definite medical opinion over here, but I can tell you this. It is possible, depends on the number of factors, depends on the location of the tumor, size of the tumor, and what exactly, other characteristics the tumor has. So certainly can't be ruled out it has to be in the right setting, and definitely need more information to give you a definite answer. But it can't be completely ruled out.
Okay, thank you very much. I'll keep researching and finding out a little bit more.
Absolutely. I wish I had a better answer for you.
It's okay. Thank you.
thank you, Sonia. Right, okay, so all that's left for me to say is our next meeting is Thursday, 31st of July at the same time. where we will have another wonderful speaker for you. And thank you once again, Dr. Arshad. Just thank you for giving us your time, and thank you for everyone for
Absolutely.
coming. But thank you very much, and we will see you hopefully all next month.
Absolutely.
Thank you.
All right.
Thank you
Thank
very
you.
much. Thank you.
Bye.
Bye-bye.
Bye.